And now I want to speak to you about emergency management of cardiac dysrhythmias. First, I want to take the situation where the patient has no pulse. These are people that are clinically dead. What do we do for them? Okay? That's the first category. So let's take this case here. A 44-year-old man complains of indigestion at work, but it's not really gastroesophageal reflux, it's a heart attack. And suddenly he falls over, he faints. Someone comes over, says, "Hey, are you okay?" Gives him a shake. He doesn't move, no response. They open his airway, they look, listen, and feel. They've called for 911, they've called for help. CPR is being done. Let's say there's no external automatic defibrillator in this office. And the paramedics come, and on arrival, they hook up the EKG monitor. And for someone who has no pulse, these are some of the possible rhythms that you might see. Okay? Certainly, you might have a patient who's asystole, just flatline. And you might have a case where someone has no pulse and the EKG looks relatively normal with PQRST. Okay? Pulseless electrical activity. There's electrical activity, but there's no blood moving. Now I want to talk about these three rhythms that you might see in someone with no pulse. The top one is ventricular fibrillation. Okay? Ventricular fibrillation is the most common arrest rhythm. This is the one we want to get defibrillated right away, right? Okay? These people are always clinically dead. They always have no pulse. The second slide down is torsade. It's a type of ventricular tachycardia. It's a polymorphic ventricular tachycardia. It has this characteristic spindle-looking pattern, right? Patients with torsades may have a pulse and even be awake. And some patients with torsades, there's not enough blood being moved about the body and they appear dead without pulse. We're talking about the pulseless situation of torsades here. The last arrest rhythm, which may not have a pulse, is ventricular tachycardia. That's the bottom one, VTAC. Okay? VTAC can occur in patients with a pulse and those without a pulse. Again, I'm talking about the situation now where they have these rhythms and they're no pulse. No pulse. Okay? So what do you do when you come around upon the situation where you have someone who has no pulse and has these three rhythms? We call these pulseless shockable rhythms. Pulseless shockable rhythms. That means these three conditions respond to electricity, electric shock, to resume a normal, hopefully PQRST, and resumption of perfusing rhythm. Okay? So you come upon these things, the first thing you want to do is defibrillate. That means give electricity now, right? And on the test questions, it's gonna say you'll see either a monophasic shock of 360 joules or a biphasic shock of 120 or to 200 joules. What's the difference? The difference is the monophasic shock is the pattern of the electrical signal as it goes through the machine and goes through the patient bodies. And these are the older defibrillators. These are falling out of disuse. These are being replaced by the newer biphasic defibrillator. And the actual physics of the electricity and the impedance, that's for electrical engineers. They're not going to ask you that on step 2. Okay? But the new biphasic defibrillators are more efficacious in reviving the dead. And the energy level used is lower. It's 120 to 200. In essence, whatever defibrillator you have, you turn it for full power and you defibrillate. Okay? Now you'll notice that the guidelines here change every few years, and that one shock is now the current recommendation. After you shock one of these three pulseless rhythms, the recommendation is to immediately resume CPR for about 2 minutes. And then check the rhythm on the EKG and check to feel if the patient has a pulse. Yes, I know if you studied this a couple years ago, it was different. So this changes every few years. You have to stay on top of it to stay up to date. Okay? If after 2 minutes of CPR you check the rhythm and the patient is still in a pulseless shockable rhythm, you shock them again, you resume CPR immediately, and we'll talk about now giving the different drugs and starting to get a more permanent airway, like endotracheal intubation. Okay. What are the drugs you can give in a pulseless shockable state? You can give epinephrine, 1 milligram, IV, every 3 to 5 minutes. Okay. Or you can give 40 units of vasopressin, IV, one time for the whole arrest. Okay? All right? And there's some variation here. These are just recommended guidelines. If you give epinephrine first, 1 milligram, 3 to 5 minutes later you can give a dose of vasopressin if you want. That's perfectly fine. Okay? Okay? If after the end of the 2 minutes you check the rhythm, they're still in the VFib, I shock them again, 360 for the monophasic, 120 to 200 for the biphasic defibrillators. Okay? I start to do my CPR for 2 minutes, and I start to add additional drugs. The next drugs you can add are amiodarone, IV push, or you can give lidocaine, IV push. When do you use magnesium? Magnesium is only for the torsades. Okay? Magnesium is not for ventricular fibrillation, nor is it for the regular ventricular tachycardia. It's just for torsades. Okay? So here's the situation. What do you do if you're standing at the patient's bedside? Picture this. They tell you you're at the patient's bedside in the intensive care unit, and suddenly the patient's eyes roll back and the patient's speech gets slurred, and within 10 seconds they're nonverbal and unresponsive. On the monitor you see the ventricular fibrillation. What do? You're in the intensive care unit of your hospital. Do you think that the patient's leads fell off? Do you think that the patient's developed Parkinson's and you're seeing an artifact on the EKG? Okay? No, this is ventricular fibrillation. So what's the first thing that you do? You're all alone in the room with the patient. Help! You scream bloody murder and get the nurses in there. Right? Okay. Because what do you want to do? What's the first thing you want to do? Someone's going to want to give you an endotracheal tube. Intubate the patient. No, that's not the right answer. Someone's going to want to start CPR and get some machine to help do chest compressions. That's not the right answer. All efforts should be to defibrillate. And since when you're in the hospital, in the intensive care unit, the defibrillator is right next to the patient, all efforts should be from getting the paddles onto the patient's chest and shocking. After you shock, if the patient does not resume a normal rhythm, a perfused rhythm, then you have time to do airway and give all the medications. All right. Let's go on to the next set of circumstances. Let's take a patient that you come upon and has no pulse, and they get their BLS care, and the paramedics get there and they put the EKG on. They're going to see one of these two types of scenarios. They're going to see asystole, the top one, which is just no electrical activity, right? Or they're going to see someone with a PQRST and a good-looking EKG on the monitor, but no pulse, and they're clinically dead. They're apneic, they're unresponsive. Okay? It doesn't have to be first-degree heart block. You can see any rhythm. Any rhythm that you think there should be a pulse, but there isn't. That's the situation we're talking about now. Pulseless, non-shockable rhythms. Electricity defibrillation will not cure this. Okay? That's the key take-home message. Okay? All right? The treatment for this is medication. We give epinephrine. We give epinephrine followed by vasopressin, just like the shockable rhythms. You could use atropine. Okay? And the main issue is to treat the underlying cause of this PEA, pulseless electrical activity. Okay? So what are the causes of pulseless electrical activity? Let's look at this for a moment. The main causes of pulseless electrical activity are, number one, hypovolemia. If the patient's bled to death, there's no pulse. So you want to start saline, ringers, O-negative blood, as much fluid as you can get. Severe hypoxia causes PEA. So you want to correct hypoxia. Hyperkalemia, hypoglycemia, acidosis, hypomagnesemia, all these things, electrolyte disorders, cause arrest. They cause the asystole. And you know what? Let me give you a hint. This is the same list you're going to think about when someone's in VFib. These are the types of causes of arrest in the type of shockable arrest and non-shockable arrest. All these patients have no pulse, this section. What else causes arrest? How about mechanical obstruction, cardiac tamponade? There's lack of blood returning into the heart. Tension pneumothorax causes an arrest. Why? Same reason. The vena cava is kinked. There's no blood return to the heart. There's no cardiac output. Massive thrombosis, like saddle embolism from pulmonary embolism. Same problem. Blood can't circulate. Okay? Myocardial infarction, same problem. The heart's so weak, so dead, there's no blood that moves around the body. Right? Okay. All right, of course, poisons. All right? So your treatment is going to be designed to correct the underlying problem. So if someone comes in asystole, and I've given them the epi, and I've given them the atropine, and I've done airway breathing circulation, and they're not getting better, I should simultaneously be thinking about the underlying cause. If the patient's on a ventilator, when this happens, suddenly they go into arrest, I bet you they've got a tension pneumothorax, and you better go palpate the trachea, listen to the lung, and decompress the chest as needed. Right? If they have an ice pick sticking in their heart and they come in a asystole or a pulseless electrical activity, I can bet you that this is from cardiac tamponade, and emergency pericardiocentesis at the bedside would be the way to go. What if the patient was in arrest and had renal failure and had missed 3 or 4 of their dialysis? What if that's the question they give you? If that's the case, I'm going to give the treatment for severe hyperkalemia immediately. I'm going to be pushing some calcium. I'm going to be giving them some bicarb through the IV. So think about the underlying cause. If it's just someone that slit their wrist and now is in arrest, and there's a pool of blood on the floor, I know I need to put my hand over the bleeding site and start IV fluids, massive amounts. Okay? Now, this last line on this slide, I'm talking about the use of pacing in people that present with no pulse and asystole. And pacing is not a current recommendation in this setting. What they're trying to tell you here is that these are people who come to you asystole. The first time you meet them, they're asystole. And they've been asystole now for 10, 15 minutes. Putting on a pacemaker is not going to bring them back. Okay? In just a couple minutes, we're going to talk about the situation of severe bradycardia and patients who are bradycardic and become asystole right in front of your eyes. Certainly, those patients, pacing is mandatory. Okay? What the guidelines are telling us here is that if you pace people 20 minutes after they died, they don't get better. Okay? All right? So if you think there's any hope that pacing will work, you can go ahead and use it, but you are justified in not using pacing in patients who have been dead for a long time, 10, 20 minutes. Okay? Is that all right? Okay. All right, so here's the algorithm, which is kind of long, that combines these two types of patients. All these people on this slide are pulseless, all right? On the right-hand side are the people that have rhythms that you can't shock. They're non-shockable rhythms, right? So for those people, you would give the epinephrine, you would give the vasopressin, you can consider atropine, right? After you give the drugs, you resume CPR, you wait another 2 minutes doing CPR, and then after 2 minutes, you recheck the EKG, you recheck for a pulse. If there's still an asystole, you can give an additional epinephrine. If the rhythm changes, if now they're in ventricular fibrillation, now I would go to the other side of the diagram, the left side, and of course that algorithm suggests you always defibrillate as soon as you can when you see VFib, torsade, or VTAC without a pulse. Okay? So this algorithm on this slide, this needs to be put to your memory because if it's an emergency, you can't go look it up. And on test day, you can't refer to your little handy pocket guide. You have to have it in your memory. All right, what not to do in an arrest. They might give you some distractors on these test questions. If someone's clinically dead, thoracotomy is out. Okay? For medical arrests, for thoracotomy, I've had a heart attack, I've died, I've fallen down. Don't do thoracotomy. It doesn't work. The only indication left for thoracotomy during an arrest is if it's like penetrating trauma to the heart and they arrest right in front of you in your hospital, in your clinic. Okay. Okay. Witnessed arrest from penetrating heart trauma. All right? That's the only time to do thoracotomy. No one else. Why? It doesn't work. Intracardiac drugs are currently out. If someone's in arrest, you do not give intracardiac epi. Okay? The only time you stick a needle near the heart is if you think they have a cardiac tamponade causing the arrest, and then you do pericardiocentesis. All right? There's no need to do 2.5-hour resuscitations on people without a pulse. Remember, we talked about the fact that after 10 minutes, you know, your rate of survival approaches 0. Truly a miracle. All right? If someone comes into you with asystole, pacemaking's not going to work. Certainly if someone's been asystole for 20 minutes, it's not going to work. Okay? You may remember the old precordial thump. That's where you hit someone right in the sternum. It's about 20 joules worth of energy. There's no current recommendation either way about the precordial thump. If you witness a cardiac arrest, that's VFib, that's a shockable rhythm. This is like giving a shock, right? So if it's the VTAC or the VFib or the torsades, if you want to thump them, you go right ahead. Okay? This is for people that have no pulse. Okay? Now, what do you do after the cardiac arrest is over? Let's take the common situation where the patient dies, right? That's the usual outcome. So before you pronounce the patient, there might be a question designed for how do you handle your staff, and the answer is that you look at your staff, you ask them if they have any suggestions, okay? And you ask yourself, is there anything else that is reasonable to do to try to bring this patient back, all right? After you pronounce the patient, thank your team for their help, all right? Then take a minute, take a deep breath, comb your hair, put on a clean lab coat. Now don't be full of any blood or secretions. And then you go speak with the family. Okay? The family's going to remember this conversation for the rest of their lives, so it's nice if you could kind of look professional while you have this discussion and explain that their loved one has just passed away. Okay. You could take a chaplain, hospital chaplain with you. That's their role, if you like. That's perfectly acceptable. Now, on the patients that you are able to bring back and resume spontaneous circulation, you have to look at that list that I just talked about for what was the cause. Was it a heart attack? Was it a pulmonary embolism? Was it a tension pneumothorax? Was it a cardiac tamponade? Is it just plain old MI? What's their acid-base balance? What's their fluid and electrolyte status? Is their glucose normal? So what you want to do is check all those parameters with your x-rays and your blood tests and your blood gas. And you want to, don't let the patients get too cold. If you're under 91.5, that's too cold. You need to warm them up a little bit. Okay? Most of these patients have airways and breathing. Most of these patients need airway and need a ventilator. Okay? The key thing to remember is that routine antiarrhythmics are not given. Just because you shock someone back from VFib does not mean that they need lidocaine or amiodarone. Okay, routine antiarrhythmics are not given. Neither are prophylactic steroids or antibiotics. Okay, no antibiotics, no steroids unless there's some other indication. Now I want to talk a little bit about prognosis of people that have suffered a cardiac arrest and have been resuscitated. If they ask you a question about prognosis, the patients with poor prognosis have, well, they're not awake. That's the main thing. They have no corneal reflex. They have pupils that don't respond even after the atropine has wore off, right? They don't respond to pain. They're flaccid. And of course, they have abnormal EEGs. So if you're not awake by 24 hours after a cardiac arrest, your prognosis is poor for resuming a normal life. Now, a key concept for these arrhythmia cases is knowing when to use a pacemaker and when to use electricity or shock. Okay? So far, we've talked about shocking. And shocking, or defibrillation, is for that pulseless shockable rhythm, right? The other times we use electricity is when you have a tachycardia and it's making the patient unstable. That means that the patient has terrible chest pain, the patient has shortness of breath, or the patient has confusion, not enough blood going to the brain. In those cases of tachycardia, by the way, the heart rate there is usually above 150, we use electricity or a shock to revert them to a normal sinus rhythm. We call that type of electric shock synchronized cardioversion. Okay? Sometimes it's referred to as just cardioversion. Sometimes it's referred to as just a synchronized shock. And what that means is when you set the machine to synchronized, it doesn't shoot the electricity into the patient the moment you press the buttons. It waits. The machine is smart. It waits a fraction of a second until it knows it's going to deliver the electricity right on top of the next QRS complex. The machine knows not to deliver the shock on top of a T wave. That's important because if you shock on top of a T wave, you could send the patient into ventricular fibrillation. All right? So, in other words, if you're using the electric shock machine, we commonly call it the defibrillator, but there's a button on there that you can press that synchronizes the shock. That's called the cardioversion. And you do that on patients who have tachycardic rhythms that are unstable that you want to convert to sinus rhythm by the use of electricity. Okay? Pacemakers, on the other hand, for step 2, are used for bradycardias only. So if the heart rate's too slow, you want a pacemaker, right? If the heart rate's too fast and they're unstable, you want cardioversion. That's a key concept. You don't use a pacemaker in someone with a heart rate of 160. That would be wrong. So let's go into the arrhythmias, and now I'm talking about patients that obviously have a pulse, okay? We're now talking about the rest of this lecture is about patients with pulse. All right, bradycardia. 47-year-old man who comes to the clinic, he's there for a flu shot. He feels fine. His heart rate's 47. Question is, what's the next best step in management? What's the next best step? A, atropine. Oh my gosh, he's bradycardic. B, EKG. Or C, do I want to put a pacemaker on? A transcutaneous pacemaker is a device that has two big sticky pads that go on the chest, front and back, and it sends electricity, or it paces the heart, and you can set the pacemaker for what rate you want, 60, 80. Okay. So what do you want to do in this man? Well, the answer is B. Just take the EKG. He does not need any emergency treatment. He feels fine. He's there for a flu shot. He's got no shortness of breath, no chest pain, no confusion. He's not unstable. Okay? Now, my 47-year-old man who feels fine, if I take the EKG and it shows sinus bradycardia, the treatment is do nothing. If he tells me that his heart rate's 47 and he's on metoprolol, I would slow down the dose of his metoprolol, right? If he's 47 years old with a heart rate of 47, feels fine, and he's on digoxin, well then I would consider that he's on too much digoxin and stop his digoxin for a day or two, right? Okay. But basically, I don't need to treat the underlying arrhythmia with atropine or a pacemaker because the man feels fine. Okay? It's the same for first-degree heart block, and it's the same for second-degree heart block. You do these all the same. There's no acute treatment. You look for the underlying cause. All right? Now, if my 47-year-old man with a heart rate of 47 who feels fine comes in, and he's on no medications, and I take my EKG and I find out that he's in a third-degree heart block, or I see that he's in a second-degree heart block type 2, or Mobitz 2, that's a problem. Because those two rhythms can progress to asystole, suddenly and without warning. So you don't want to leave him with third-degree heart block at home. Then you would put him in the hospital on a cardiac monitor and arrange for a transvenous or permanent pacemaker. All right, now, let's take a slightly different case. Let's have a symptomatic bradycardia. Symptomatic means what? They have symptoms. They're dizzy, they're sweaty, they're cool and clammy, they've been having fainting spells, they had chest pain, they had shortness of breath, they're confused. Okay, they don't feel good. Okay? If it's a symptomatic bradycardia and their heart rate's less than 60, now we need to take some emergency action to speed up the heart rate in addition to, finding the underlying cause. So this is the person that gets the IV atropine. Okay? That's the first step, IV atropine. Give it a try. Does it work better with certain rhythms, certain bradycardias than other? The answer is yes. It might not work with third-degree block. It might not work with Mobitz type 2, second-degree block. It's worth a try. It's not a lot of side effects. Atropine is the first-line drug. If the patient responds, the heart rate comes up, the symptoms resolve, you've temporarily alleviated the crisis. Okay? If the atropine doesn't work, the next best step, the next thing to do, is the transcutaneous pacemaker. It's easy to do. You put the sticker here, you put the sticker here, you plug the machine into the wall, you set the heart rate for how fast you want it, you hit go. So within a matter of seconds, I can begin pacing a patient. All right? Why don't we just put a transvenous pacemaker in? Well, if the patient's having an emergency, you don't want to leave them having angina for the hour it takes to get a transvenous pacemaker in. Transvenous pacemaker requires putting in a central line. It's invasive, takes time to set up. If you do it in a rush, you tend to make mistakes and give people pneumothoraces, right? All kinds of problems. So the transcutaneous pacemaker's advantage is that it's very, very quick. Within a minute, you're going up and running. If for some reason you don't have a transcutaneous pacemaker, it's at the shop out for repair, for some reason it doesn't work, the next thing you can do to try to speed the heart rate up, the third-line drugs, in other words, a third-line treatment, is you can use a dopamine drip, or an epinephrine drip and titrate the drip to the patient's heart rate till you get it up above 60. All right, so here's a classic question. When would you give a patient with symptomatic bradycardia IV glucagon? And the answer is beta blocker overdose. Okay, sometimes they like to ask that one. All right, let's take a look at the EKG for a minute. There's not a lot of EKGs on step 2, but you do need to recognize the heart rate on the rhythm strips. Okay, so here's a normal rhythm strip. It's PQRST. And how do you remember what the heart rate is? Well, what I remember is if the QRSs are one big box apart, that's the tall spikes, the heart rate's 300. I have it memorized. Okay? If the big spikes of the QRS complexes are two big boxes apart, the patient's heart rate's 150. By the way, if someone's heart rate's exactly 150, what's the most likely rhythm? It's A flutter with 2-to-1 block would be the most likely rhythm. Okay. 3 big boxes, the heart rate's 100. 4 big boxes, 75. 5 big boxes, the heart rate's 60. 6 big boxes, the heart rate's 50. So I basically remember if the QRSs are between 3 and 5 big boxes apart, your heart rate's between 60 and 100, it's normal. Okay? If you want to get more scientific, you can take the 300 divided by the number of big boxes, the QRSs apart, and you'll get the same answer. Okay? So that's how you do the heart rate. So you're going to ask me, well, maybe sinus bradycardia is a symptom for some disease. What else should I be thinking of for sinus bradycardia? And the answer is a lot of time it's normal, right? Very common with athletes, right? Someone that's experiencing vasovagal syncope will have any type of bradycardia, including sinus bradycardia, during the time where they're feeling faint. Okay? All right? Inferior wall MI affects the sinus node and brings on bradycardia. So bradycardia is common in inferior wall myocardial infarction. What happens when you vomit? The vagus nerve is stimulated. So that also makes you bradycardic. Okay? Don't forget to always take the medication history. Digoxin, beta blockers, calcium channel blockers all cause bradycardia. And in most questions, they're going to give you the vital signs. And if you see hypothermia, that's could be a cause of bradycardia. And lastly, we always think of hypothyroidism, bradycardia, hyperthyroidism, tachycardia. The first degree AV block is defined as a PR interval greater than 0.2 seconds. That means the PR interval is greater than one big box. Okay? The PR interval, you measure that from the very beginning of the P wave to the very beginning of the QRS. And that's the PR interval. All right? So I don't even look for it most of the time because it's not all that helpful. It could be a normal finding. You see it in people that are a little older. You see it in common when people take digoxin. Anyone with the vagus nerve is stimulated, that's going to be a little more prominent. But you can also see it with ischemia, cardiomyopathy, and of course we all know elevated PR interval or lengthened PR interval as a criteria for rheumatic fever. Okay. Okay. No treatment. No treatment. Now here's a tricky one. You remember there's 2 types of type 2 block. There's Mobitz 1, that's the winky block, that's the not dangerous one. And there's Mobitz 2, that's the dangerous one. It's dangerous because it can progress to asystole. Which one is this? This is kind of a mean question, a little bit of a trick. When it's 2 Ps to a QRS, it meets the criteria for both Mobitz 1 and Mobitz 2. You can't really tell from the information provided here. You would have to take a much longer rhythm strip and wait till it declares itself to see some of the characteristic criteria. What are those criteria? In Mobitz 1 or winky block, what you see is lengthening PR intervals. The first PR interval is this long, the second PR interval might be like this, the third PR interval is like this, and then there's a P wave followed by no QRS, and then the cycle restarts. A PR interval this long, the next beat has a PR interval this long, the next beat is this long, and then there's a P wave without a QRS. All right. So you treat the underlying cause. Is it too much vagus stimulation? Is it too much digoxin? This rarely goes to asystole. It's a pretty stable rhythm. The moment it's type 2, second degree block, you recognize that because the PR interval is constant. What happens is you have a number of beats with a normal PR interval, and then there's a P wave and nothing, no QRS. There's a little pause, there's a second P wave, and then a normal PR interval until the next dropped beat. And that's the dangerous one. The problem is it may just progress to just P waves with no QRS complexes. That's essentially asystole. This you see with anterior wall MI. So patients with anterior wall MI, this is more common, and they commonly need their transcutaneous pacemaker. Third degree heart block or complete heart block means there's no correlation between the P's and the QRS's. Remember, if you take your caliber and march out the beginning of the P waves to the beginning of the QRS's, you will see that there is no relationship between the two. Okay. So here's the algorithm, put it all together for the bradycardia. We're talking about, I guess I should have mentioned, bradycardia is heart rate less than 60. Yeah. And what you want to do is someone comes in with bradycardia, if they're in the emergency room, it's, IV, O2, cardiac monitor, give some oxygen if you need, order a 12-lead EKG, ask the patient if they're stable or unstable. How do you do that? Are you having any chest pain? Are you shortness of breath? Are you confused? Are you awake? Is your blood pressure very, very low? Okay. If they're not unstable, that means they're adequately perfused. All you need to do is take the EKG and treat the underlying cause, right? No atropine, no pacemaker, no transcutaneous pacemaker. If they're in high degree heart block or third degree heart block or second degree type 2, then you'd consider a transvenous pacemaker. If you have poor perfusion, the right-hand side, these are the people who are unstable. They're confused, they're short of breath, they have chest pain. These are the people that need immediately need atropine. If that doesn't work, transcutaneous pacemaker. If that doesn't work, epinephrine or dopamine drip. Okay? And you'll notice in the left-hand corner of this slide the causes of bradycardia, and they're very, very similar. It's the same list as the causes we went over for cardiac arrest. So anyone who has an unstable heart rhythm, we're always trying to look for the underlying cause. Okay. Next, I want to talk to you about fast heart rates, palpitations. Okay, so this is people with a pulse whose heart rate's going too fast. So the stem of this question is going to look something like this. I have a 28-year-old female or male, and they got alcohol or alcohol withdrawal or nicotine or cocaine or some reason, whether thyrotoxicosis, and their heart rate's 160. They have a pulse, their heart rate's 160. How do I approach this? I'm thinking about what the rhythm can be. Our natural mind is to go, well, is it supraventricular tachycardia? It could be. Is it atrial fibrillation? It could be. Is it multifocal atrial tachycardia? It could be. Is it ventricular tachycardia? It could be. Don't let the low age fool you. It could be ventricular tachycardia. Could it be a torsade, polymorphic VTach? It could be. Okay? Because all I know is the heart rate is 160. I haven't seen the EKG yet, right? To decide what to do next, our choices are going to be give medicine or cardiovert. Remember, electricity, synchronized cardioversion. How do I decide what to do? You decide based on talking to the patient, not what the EKG looks like. If the patient is stable, that means, other than feeling their the pounding in their chest from the palpitation. They have no angina. They have no syncope. They're not sweaty and diaphoretic. They're not confused. They don't have severe shortness of breath. They're stable. That person, you give medicine to slow the heart rate or fix the heart rate. If the patient has any of those symptoms, they're unstable. They need electricity, cardioversion, to correct and break the tachyarrhythmia. So how do we define stable? Chest pain, shortness of breath, confusion. That's the easy way, right? All right. And yes, I mean confusion acutely, not that they have Alzheimer's and been confused for years. Okay. You'll notice that I'm not using the blood pressure as an absolute indicator of stability. Isn't that interesting? Because the blood pressure you have to interpret in terms of the patient's body habitus and their age, right? So, you know, if I had a blood pressure of 85 systolic, 85 over 60, and I was confused and dizzy, I would be unstable, okay? And I would need, if I had a tachyarrhythmia, a cardioversion. A 28-year-old, 90-pound woman, her normal blood pressure might be 85 over 60. So if she feels fine and has no shortness of breath, no chest pain, and no confusion or syncope, you don't want to be doing cardioversion on her. Doctor, I have some fluttering in my chest. It started about 5 minutes ago, and I feel fine. I just noticed this little fluttering. And the blood pressure is 85 over 60. You don't want to push her down and cardiovert her, right? Okay. Similarly, we don't use low urine output. We discussed it before. Why? Because it takes too long to collect the urine output over 30 minutes. So here's some typical palpitations, some fast heart rates. The top line is atrial fibrillation, the irregular pattern. The QRSs can be narrow, right? Or the QRSs could be wide. We call that aberrancy, wide QRSs. Okay? The second line is multifocal atrial tachycardia. And these have three different morphologies of P waves. Okay? This is more commonly seen in people with COPD. And the last one is more of a SVT atrial tachycardia that should be pretty regular. And it is the most likely thing that the 28-year-old in the previous slide, in this previous case, has. All right? Here's some other things that cause palpitations. These are people with a pulse, right? Remember, VTAC can be pulse or no pulse. Now we're talking about VTAC with a pulse, torsades with a pulse. So after I decide if they're stable or unstable, the next big decision is it wide or narrow? I mean the QRS, is that wide or narrow? So I look at the QRS duration. If the QRS duration is 3 small boxes or bigger, that's 0.12 seconds or longer, that is a wide tachycardia, a wide complex, wide QRS. If the QRS is 0.11 or less, it's narrow. Okay? Okay? So here's the deal. If it's a narrow QRS, it's always an atrial tachycardia. If it's a wide QRS, the tachycardia can be narrow, or if it's a wide QRS, the tachycardia can be ventricular or atrial. If it's a wide QRS, the tachycardia can be ventricular or atrial. If you're not sure if it's a very wide complex, you're better off assuming that it's ventricular if you can't make up your mind. The treatment is safer. Okay, let's talk about the case of a wide and regular tachyarrhythmia. That's going to be either ventricular tachycardia or it's going to be SVT with aberration. Okay? All right? And I would err on the side of calling this ventricular tachycardia, and the treatment there, if they're stable, is going to be amiodarone. Okay? Amiodarone. If you're really, really sure that this wide, regular, rapid rhythm is SVT with aberration, then you can treat it with adenosine, the treatment for SVT. But if you give adenosine to VTAC, you might induce asystole, so You better be sure. Err on the side of giving amiodarone in this situation. If it's wide and irregular, your possibilities are torsade, which has that characteristic spindle shape, and that you treat with magnesium, like we covered earlier. It could be atrial fibrillation with aberrancy, right? Or it could be an uncommon thing called Wolff-Parkinson-White, WPW, right? And atrial fibrillation on top of that, all right? Now, what if your rhythm is wide and irregular? And we're talking about tachycardia here. What are the possibilities? Well, it might be torsade that has the characteristic spindle shape, and we already know that magnesium is the treatment of choice there. It might be atrial fibrillation with aberrancy. Okay. And if you really know it's atrial fibrillation with aberrancy, we can give our standard drugs for atrial fibrillation, which are beta blockers, calcium channel blockers, and digoxin. The problem is, this wide and irregular rhythm might be WPW with atrial fibrillation. And if you give them the standard drugs for atrial fibrillation this time, the calcium channel blockers, the beta blockers, and digoxin, the patient will get much sicker and possibly be fatal. Maybe induce ventricular fibrillation in this case. Because WPW with atrial fibrillation will also give you a wide, irregular rhythm, and of course these patients are treated with amiodarone. Okay? So we'll see that when it's wide, amiodarone comes up a lot as a treatment drug, which is safe in these situations. Okay? What are the downsides of amiodarone? Well, hypotension, and it increases heart block, so they're contraindicated in second and third degree heart block as well. Lastly, amiodarone is a negative inotrope. So if you're giving IV amiodarone and IV beta blocker together, or amiodarone and calcium channel blocker IV together, you might induce pulmonary edema and congestive heart failure. So what we've been talking about this last section is displayed here on this slide. This is the entire algorithm for patients with pulses who have a tachyarrhythmia, heart rate 150 and up. And if you just follow it down, it goes through all the different pathways that we just discussed. Everyone gets IVO2 monitor, cardiac monitor, and a rhythm strip, and a pulse ox. Then in that big pink box, we decide if the patient's stable or unstable. I still don't have a 12 EKG, okay? I just know the patient has a tachyarrhythmia. If the patient's stable, they get drugs. If the patient's unstable, they get cardioversion. Then I get my 12 EKG and I scrutinize this EKG for any clues about the origin of the rhythm. And most importantly, I'm looking to see if the QRS is wide or narrow. Okay? If it's a wide QRS, I'm on the right-hand side of the column. If it's a narrow QRS, I'm on the left. So let's discuss the narrow QRSs now. If it's narrow and regular, that is supraventricular tachycardia, and that is cured, converted back to sinus rhythm often with the use of adenosine, IV adenosine. Okay? We expect when we see SVT that we will be able to convert this back to sinus rhythm with the use of 6 milligrams IV adenosine IV push. Okay? If the QRS is narrow and irregular, now we're in the situation where it's most likely atrial fibrillation or multifocal atrial tachycardia. These two rhythms do not convert to sinus rhythm if you give adenosine. They will slow down transiently and then speed right back up when the adenosine is metabolized. Right? So for these rhythms, our goal is to lower the heart rate so that the patient is able to perfuse better. But I'm not expecting when I treat this urgently that I will convert them to sinus rhythm. So the drugs to slow down fast atrial rhythms are what? IV beta blockers, IV calcium channel blockers are the first two. Now the question will usually give you some other clue as to what's the better drug. If they tell you they have rapid atrial fibrillation that's narrow QRS, the heart rate's 180, the patient is stable, so no electricity, and they need a medication, there'll be something else in the question that'll help you choose calcium channel or beta blockers. If they say they have the worst asthma in the world, you'll choose the calcium channel blocker, right? If they say the patient also has thyrotoxicosis, well then maybe the beta blocker would be a better choice, all right? You could also use digoxin. That's falling out of favor because it takes longer to work and lower the heart rate. So let's take a case. Let's pretend the president is suddenly ill with a fast heart rate of 170, narrow complex, he's stable, there's no chest pain or confusion or shortness of breath, and you find out, also know that the patient has Graves' disease. What would be the best drug to slow the heart rate down? And the answer in that case would be the beta blocker, metoprolol. All right, let's take another case. What if you have someone who's in atrial fibrillation? When do you worry about blood clots forming in the atria? The reason you don't want blood clots forming in the atria is after you convert them to a sinus rhythm, the blood clots may leave the atrium and go around the body and cause stroke, right? So in our best test-taking skills, we look at the choices here and we see the answer is 48 hours, okay? If someone's in atrial fibrillation for 2 days, you better start worrying that there are blood clots in the atrium. And in this case, we either need to anticoagulate the patient prior to resuming sinus rhythm, or we need to do a test to prove there are no blood clots in the atrium. And the best test for that is transesophageal echocardiogram. More on that in the cardiology section of the series. So let's try this case. How are you going to manage this guy? 57-year-old, stands up, gets lightheaded and is confused. Blood pressure is 130/88. He has monomorphic VTAC on the EKG. So it's VTAC with a pulse. Blood pressure's fine. And the question is, what's the best step in management? Well, remember, what's the first thing we have to do? Is he stable or unstable? Well, he's confused. That implies that there's not enough blood going to the brain. So that is unstable. The answer for this man, despite his normal blood pressure, is synchronized cardioversion, because he's not stable with that word confusion. Well, that ends our section on cardiac dysrhythmias. Thank you.